Hi everyone. Thank you for listening to me today. So currently I work at the Brain and Mind Centre and coordinate the motor neuron disease clinic. We service all areas of Sydney, interstate, overseas as well. We run also a multidisciplinary clinic every 2 weeks on a Thursday, and so recently staffed specialist physio and occupational therapist, as well as our health psychologist and neurologist, Dr. Damadasa. So today I thought I'd give us an overview of the various subtypes of motor neuron disease, because it has a lot of implications on our management as well, and then thought we'd go through some of the research projects and trials that we're doing at the Brain and Mind Centre, which are current and up and coming as well. So first of all, looking into the phenotypes, different physical presentations of motor neuron disease, the brain and spinal cord donation program, some of the clinical trials. One that's current at the moment is the Lighthouse trial, looking at an antiretroviral medication in case the MND has a viral cause or origin. And two more drugs which are up and coming are Devarone, which you might hear in the news, recently FDA approved in the US, and Multidisciplinary, hopefully in the next 12 months might come to Australia as well. And also we have another project that I thought I'd cover, looking at PET imaging and cortical excitability. These are some of the famous faces you might recognize in Australia of patients who've had motor neuron disease or currently have it. The first one you might recognize is a patient we looked after, Peter Doohan, who was otherwise known as the Becker Wrecker. He, famous, fantastic guy. Unfortunately, his disease progressed very quickly. Within a few months, he'd passed away post-diagnosis. But he defeated, Boris Becker, who was a 2-3-time Wimbledon champion. Another one is Angie Cunningham, who recently passed away as well, a tennis champion. Pro Hart, one of our famous artists. Everyone knows Neil Danaher, who is a big advocate for the Cure for MND Foundation. And also another patient we looked after, James Kemsley, who's a Ginger Meggs cartoonist who had ALS. So MND is a neurodegenerative disease resulting in progressive weakness in the voluntary muscles of the body, and it's secondary to degeneration and loss of motor neurons within the brain and the spinal cord. Now, other terms that it can be known as is amyotrophic lateral sclerosis, which was the MND was first described by Jean-Martin Charcot, and he was a French neurologist in the 1860s. And he named it amyotrophic lateral sclerosis in about 1874 after he looked after a number of patients who presented with quite severe muscle wasting and weakness. And on post-mortem examination, what he saw was, if you see in the diagram here, this is a cross-section of the spinal cord. He saw here in the corticospinal tract hardening or sclerosis, sclerotic plaques, which is the path that the motor neuron takes, and he saw some muscle wasting. So that's how the name amyotrophic lateral sclerosis came about, A meaning absence of muscle nourishment because of the hardening, which is the sclerosis, of the lateral side of the spinal cord. And this over here is Jean-Martin Charcot. So that's how we first got the name ALS, which is a name this is often used in the US. In Australia and the UK, we usually refer to it as motor neuron disease. It's also known and named after him, Charcot's disease, Maladi D. Charcot. And another famous New York Yankees player, Lou Gehrig, he developed motor neuron disease. You guys must have heard about him. And so they named the disease after him. So he was a very famous New York Yankees player who, after 2,100 consecutive games, he benched himself because he started fumbling the ball. His swing was out of whack. He started dragging his feet. A few months after he benched himself, he was then diagnosed with motor neuron disease, and 18 months after that, he unfortunately passed away. So his disease progress was also quite quick, and so that's how the name Lou Gehrig's disease came about. So as the motor neurons deteriorate, see on this diagram here, you've got a nice, healthy, normal cell with the cell body and the axon here, and a nice plump muscle. And as the motor neurons deteriorate, the signal that goes from the brain to the muscle gets too weak to make all of these muscles contract. And so that's how you get the wasting of the muscles. So this causes weakness, and as it continues to degenerate, the muscles become weaker and they waste away. The incidence and prevalence of motor neuron disease in the world is 1 to 3 per 100,000, the incidence, 5 to 8 per 100,000 prevalence. There's approximately 2,000 people living with MND in Australia at one time, and those are the stats from the Deloitte Economics Report in 2015, and just over 700 MND deaths per year. 2 people diagnosed with MND in Australia each day, which is actually twice as much as those patients who are diagnosed or who die from HIV. So I think it's quite common. There are more males to females in terms of the ratio or incidence, 1.7 to 1, and it's more common in middle ages, between the ages of 40 and 65, and it increases with each decade as you go up from 40s to 50s to 60s. It increases. I mean, we have patients, our youngest patient would be 24, and our oldest are well into the 90s. There's a newspaper article from the Sydney Morning Herald which reported that the incidence of diseases, neurodegenerative diseases and neurological diseases like Alzheimer's, Parkinson's disease, and motor neuron disease actually increased in the Western population over the past 20 years, except for in Japan. But as soon as the Japanese people left Japan and moved to other Western countries, the incidence of MND, Alzheimer's, Huntington's, Parkinson's increased in their population. Quite interesting. Over here is the mortality rate in Australia, and as you can see, it's really increasing over the years. The combined of male to female mortality was just over 238. In 2005, 499 passed away from MND, and the stats from 2015 is 752. It's quite significant, isn't it? Here is a diagram, I like this diagram, it's quite clear, of the patient's motor cortex, and that's where all voluntary muscle begins, muscle movement. So you've got upper motor neurons which travel from the brain to the spinal cord, and then lower motor neurons that go from the spinal cord to the muscles. So the cell body of the upper motor neuron is located up here in the motor cortex. The axon then runs either to the bulbar or the brainstem or to the spinal cord, and then the message is transmitted over to the lower motor neuron, which then sends the message through to the muscle. So here is a cross-section of the spinal cord at these levels. So here we've got the corticospinal tract, where the axons of the motor neuron are traveling to the spinal cord and then crosses over here and transfers to the lower motor neuron, which takes the message to the muscle. So the different types and subtypes of motor neuron disease are classified according to the presence of upper motor neuron problems and lower motor neuron problems. So when a patient undergoes a clinical examination, neurological examination, what we're looking for is the presence of upper motor neuron and lower motor neuron signs. So if a patient has a problem with their upper motor neuron starting to become affected, what you'll find is you'll have a person who's quite stiff, they're hyperreflexic, they have a lot of muscle spasms, they might have a bit of emotional lability. Some people call that emotional incontinence. So that's like an inability to control your emotions, and they have other problems and signs and symptoms with your reflexes. So you have preserved reflexes in wasted limbs. So patients with upper motor neuron problems, I kind of visualize them and as in the Wizard of Oz, like the Tin Man. Patients with lower motor neuron problems are more like the Scarecrow. So they have very weak muscles, wasted muscles. They also have fasciculations, which are involuntary muscle contractions, which give us an indication that there's problems with the lower motor neuron, and you have reduced or absent reflexes. So this is just some diagrams of the different lower motor neuron signs. Here you've got some muscular fasciculations. So fasciculations can happen in any voluntary muscle of the body, including your tongue and your limbs, everywhere. They can come and go. They can be quite distressing and painful for some patients, but otherwise patients usually just get used to it. Here is some muscle wasting here in the shoulder girdle of a patient who has a variant called Flail arm. some wasting here of the intrinsic hand muscles, the APB muscle, some tongue wasting, and muscle wasting here, which is quite significant. So it leaves the joints quite exposed and vulnerable to damage as well. Motor neuron disease is the umbrella term. There are various subtypes, and I thought I'd just quickly go through 4 main subtypes. The first one being amyotrophic lateral sclerosis, which accounts for 66% of all cases. It's the most common form of MND. It can begin in the vulvar muscles or in the limbs, either the upper limb or lower limbs, and this type of motor neuron disease has both upper motor neuron and lower motor neuron symptoms. So patients will present with muscle wasting, weakness, they might have emotional lability, and they might be hyperreflexic as well. We can get a more definitive diagnosis if the symptoms are found in more than one region. So if it affects, for example, bulbar region, upper limbs and lower limbs, we're looking at more of a definite diagnosis. Survival is approximately 2 to 5 years from symptom onset. Progressive bulbar palsy, or some people refer to it as isolated bulbar palsy, some of the signs and symptoms are dysarthria, slurred speech, dysphagia, which is swallowing issues, hypernasal speech, hypersalivation or siluria. So you can get excess saliva, thin saliva or thick saliva, and patients also have the tongue wasting, fasciculation or spasticity, and they have the pseudobulbar effect, which can be quite distressing. Patients think that they're going mad because they're unable to control their emotions, and they can be inappropriate emotions as well. A situation might not be funny or might not be sad, and they're not able to control their emotions. They might be crying, and then they think they are going mad. Another symptom associated with this type of motor neuron disease is neck weakness, which is a lot of physios and OTs and orthotists will know is such a very hard symptom to manage. This is a patient who's got quite severe dropped head syndrome, and these various stages of the disease, she wore different supportive collars, soft collar, Philadelphia collar, and Miami collar, which most patients find are very uncomfortable. It tends to affect their speech and swallowing and their ability to swallow their own saliva. So that neck weakness is usually a part of progressive bulbar palsy and ALS as well. Primary lateral sclerosis affects only 3 to 6% of patients, and these patients have only upper motor neuron problems. So they're like the Tin Man, with a lot of muscle spasticity and stiffness and very hyperreflexic reflexes. Lower motor neurons are not affected, and their survival is approximately 10 years. Now, progressive muscular atrophy, a type of PMA is called flail arm variant or flail leg variant. This is otherwise known as man-in-the-barrel syndrome. And so predominantly are lower motor neuron features. So you've got PLS, upper motor neuron features, and PMA or flail arm variant, low motor neuron features. Disease progression is slower and it affects more males to females. So imagine you've got a barrel, put it over a patient, that's what they're left with in terms of their function. A lot of proximal upper limb weakness. The genetics of motor neuron disease, 5 to 10% of MND is familial, and they've been able to isolate the gene that causes 20% of that group of genetic MND, and that's a mutation, the superoxide dismutase gene in chromosome 21. More recently, in 2001, Rebecca Ahmed will be probably covering this, they discovered a C9orf72 gene, which is found in patients with frontotemporal dementia and also motor neuron disease, and accounts for more than 40% of familial cases and 10% of sporadic cases. Diagnosing motor neuron disease, we call MND a disease of exclusion, and what we need to do is exclude any possible explanation of that patient's symptoms. We want to make sure they haven't had a stroke, they don't have MS, Huntington's, Parkinson's disease, any brain spinal cord pathology like malignancies. So the patients go through an array of tests, including MRIs, CTs, blood screening, lumbar punctures. It's a lot, and these poor patients get very overwhelmed. The average length of time it takes to diagnose someone with MND is 14 months, and a study that was done using the Scottish Registry showed the accuracy, diagnostic accuracy of neurologists getting it right was 93%, which is pretty good. But that also encourage us to encourage patients to also get a second opinion as well. So most of our patients will have 2, 3, 4 opinions. In terms of treating MND, there are about 6 main areas of treatment. There is no cure because we don't know what the cause of MND is. Riluzole therapy is the only medication that's available and effective in MND, and it can increase life expectancy by 4 to 6 months. And what it does, it inhibits the release of glutamate, as you can see in this diagram here. Glutamate is a neurotransmitter that's in the brain, and what they found in MND is there's excess levels of glutamate, and glutamate is toxic to the nerve cells. So what happens is when the nerve cells die, they release glutamate. This makes the nerves become very excited, and they get overexcited and excite themselves to death. So unfortunately, because we don't know what's making these levels high, we can't actually stop it, but we can reduce the rate at which the glutamate gets to those toxic levels, which is how prognosis can be improved by 4 to 6 months in MND. Another treatment is multidisciplinary care. Multidisciplinary clinics are now much more common. When we first started 15 years ago, there was only 2 MND clinics, and there's a lot more nowadays, which is fantastic. They're usually based either in public hospitals or rehab facilities or hospices. There was a study done in Ireland that looked at a population-based study and looked at the effect of people attending multidisciplinary clinics and compared it to patients who only went to private neurology clinics and saw neurologists. And as you can see from this survival curve, patients attending the ALS clinic, which is the dashed line, did better in terms of survival. The actual numbers, so patients lived 200 days longer if they attended an MND clinic, which was equivalent to about 9.5 months, 7.5 months. But the people who did, the group of patients that did the best in MND clinics were patients with bulbar weakness. And I think that's probably because of the aggressive way that we can treat them in MND clinics. It's staffed by allied health, it's staffed by dietitians, as well as speech pathologists. We can introduce the concept of PEGs earlier and get PEGs in earlier as well. So the more aggressive we treat it, the better the survival. So patients who attend MND clinics do a lot better. Respiratory support in the form of non-invasive ventilation has become standard care in MND now, and it's shown to actually improve survival by 12 months. So non-invasive ventilation actually has a better effect than riluzole does. And it also improves quality of life. A person who has sleep-disordered breathing usually has a problem with fatigue. They have daytime fatigue, headaches, they have poor quality of life. Upon commencing NIV, that improves markedly. Now, some of the research studies that we're doing in the Brain and Mind Centre, we are continuing to participate in the Australian MND Registry, which is set up in 2004. We also have a brain and spinal cord donation program. One of our researchers, psychologist Jaz Deshel-Saga, is looking into cognition and apathy in MND. Another neurologist, Tanuja Damadasa, is looking into prognostic markers and disease progression. Some of our Japanese colleagues who are with us are looking into the diagnostic utility of nerve and muscle ultrasound. And another very important thing is the technique of cortical excitability, threshold tracking cortical excitability, which is looking at the excitability of the cortex. And we're using that technique and looking at phenotypes. We're looking at the effect of non-invasive ventilation on the excitability of the brain. And we're also comparing the results from cortical excitability and comparing it to PET imaging. One of our Chinese colleagues is now looking at also cortical excitability in the Chinese population here in Australia, and then she'll go back to China and continue that study. Some of the clinical trials, like I said earlier, Lighthouse trial, which is the antiretroviral drug used at the moment that we've finished recruiting and in the middle of. Flex 202 is a medication used for muscle cramping. We haven't had success in recruiting for this particular trial. Devarone is up and coming, and masitinib is up and coming. So I thought I'd just briefly talk about that. All right. The Australian Motor Neuron Disease Registry was first set up in 2004, just after Riluzole was first PBS approved. Just out of interest, before 2004, patients had to actually pay for Riluzole, and that cost $1,000 a box, which only lasted a month. So at the moment, fortunately, it only costs $30 to $40 per box of Riluzole. So the registry collects de-identified data of patients, including their demographics, when they were diagnosed, how they were diagnosed, what tests that they underwent, how many neurologists they saw, are they on Riluzole, when did they start Riluzole, and what type of allied health professionals that they've seen and encountered as well. So at the moment, we have what we call an opt-out registry. So everybody, we notify our patients that we will put their information into the database unless they want us to not do that. So then we'll give them information about the database, and then they can opt out if they choose to. Patients are followed up every 3 months, which is actually coincides with their clinic appointments anyhow. How many patients have we registered? I think we've had, is it 2,500? I think we've got 2,500 patients registered in the database, and we have about approximately 1,000 who have active information in the system. Okay. So the MND registry it improves patient care through observing patient management by collecting the data that I spoke to you about, and allows us to evaluate outcomes such as the looking at non-invasive ventilation, the outcome of that. Does the patient's, for example, forced vital capacity improve? And also, it's important in also linking patients to clinical research, because we're able to get a current picture of what our patients are looking like in the community. We're able to also classify them according to their subtype, and trials can be based on that particular subtype, which can give a more accurate outcome. Now, one of our neurologists, Thanuja Damadasa, she's looking into the phenotypic variability in MND. So what does MND look like? Now, and what are the clues to the site of origin and pattern of disease spread? When patients are first diagnosed, what are the first questions they ask you? What's my prognosis? How will my disease spread, and how quickly will it spread, and are there any treatments? So what we're looking for is markers in prognosis and how to find clues as to how the disease spread. So in our study, we're looking at all of MND patients, and then they're classified according to subtype, PMA, like I said, PLS, ALS, and also progressive bulbar palsy. So they're categorized according to that, and then they're classified according to the certainty of the diagnosis. So it's using the Iwagi criteria. The criteria that used to be used earlier was called the Ellis-Scory criteria, and that's now incorporated into this Iwagi criteria, which tends to help in clinical trials and classification. So patients are classified according to their subgroups. Anybody can participate. There's not many exclusions at all. And what we're looking at in this particular study is we're looking at the whole neuroaxis. So the type of testing that Thanuja does will be a full neurological examination, the ALS-FRS score, which I think you might be familiar with, but I'll just show you a slide on that, the upper motor neuron score, and then the manual muscle testing score as well. The ALS-FRS here, revised, examines 9 domains of the activities of daily living, and more recently the revised version incorporates 3 respiratory functions and assigns scores from 0 and all the way to 4, which is the maximum. The maximum score you can score is 48. We tend to do this on patients every time they attend clinics, and what we found is in ALS patients they tend to lose a point or decrease their score by 1 point per month. So the ALS-FRS is a validated tool. It's been used for the past 10 years in many clinical trials. It's very sensitive to patients' condition, and it helps to track disease progression and milestones. So for example, one of the categories is speech. So you would score a person 4 if they had normal speech processes. If they had some detectable speech disturbance, so maybe a slight slurring, they would score 3. If they had to repeat themselves in conversation, then they would score a 2. And if they used, for example, an iPad with an app, a speech-to-voice app, then that would be a score to 1 because they're using speech combined with non-vocal communication. If a person is completely anarthric, has no speech, they would score a 0. So it's pretty straightforward. So FRS is used a lot in clinical trials, a very useful, validated tool. Another technique that we use a lot in our studies, as I showed you before, is this thing called transcranial magnetic stimulation. This threshold tracking technique is unique to actually our Forefront Clinic. It was first kind of worked out by Professor Steve Vucic, who's based at Westmead, and also Professor Matthew Kiernan. They first looked at a group of actually SOD1 patients, 28 patients who had the mutation, and they did transcranial magnetic stimulation on them. Not everybody in that 28 patient group knew if they were going to develop the disease or if they actually had the gene itself. So when patients underwent this TMS study, what they remarkably saw was that they detected cortical excitability. So the way that this test is done is there's a metal coil, a magnetic coil here placed over the patient's head around the part where the motor cortex is, and then it delivers a current that stimulates the motor cortex. That causes a muscle twitch here in the hand, which is involuntary, and that response is recorded here on the computer. Using specialized software, they're able to look at how excitable the cortex is. What they found in this group of 28 patients was, it was a big discovery, hyperexcitability of the cortex preceded the development of their symptoms. So patients who came and were studied, they were asymptomatic, but when Prof. Kiernan and Prof. Vucic did this TMS on them and they saw hyperexcitability, they could predict that these patients were going to develop MND. And sure enough, they did develop MND within the 12-month period of time. So this is a fantastic technique for early diagnosis. And what is the importance of early diagnosis is early treatment. And with more and more trials, more and more treatments, that's going to be even more important. So you want to delay the disease right in the beginning stages of the disease before they become disabled, more disabled. So TMS, great diagnostic tool, and it helps us to understand MND pathology. This is like a diagram of the cortical representation of the body. So TMS, in this study that Tanuj is doing, we're doing a new technique in terms that we're doing TMS on lower limbs as well. So we're looking at the complete body. We're doing TMS on upper limbs, lower limbs, doing MRI, DTI scans on these patients, full neurological examinations, and they're followed up on a 3-monthly basis. So on the cortical representation, you can see here, big representation of a person's mouth, and here is their lower limbs. So anatomically, that's quite hard to access. So doing the TMS, I showed you the picture of the metal coil. You've got to get the coil in the right spot to be able to stimulate the leg. So that's probably why not many people have done TMS in the legs before. So in our group of patients, everybody will be getting that. And that's going to help us to look at disease progression, especially in the lower limbs, which is said to be quite different compared to the upper limbs. It's going to help us to predict pattern of spread as well. Another thing that we're doing at the moment is looking at PET scanning and cortical excitability. So FDG is a, what do you call it? What's the word? FDG? A tracer of glucose metabolism. So what we're looking at is we're scanning patient's brain, doing a PET scan. With the PET scanning, patients receive this intravenous tracer, and what it picks up in the brain, in this nice diagram here, is areas of increased glucose metabolism. So that means if there's heightened areas of glucose metabolism, more energy is being used, isn't it, in those areas? So in those areas, does that correlate to the results of the TMS? So that's what we're looking at here. So doing a longitudinal study looking at cortical excitability and metabolic changes, and doing this every 3 months. And we got a grant through the MND which ends in June, July next year. I think we've recruited 10 patients so far. The Brain and Spinal Cord Donation Program is a unique program. It allows for medical research following death. It allows us to identify the specific cellular changes occurring in the brain and spinal cord of patients with the disease. So any of our patients who have MND or FTD are able to participate in this. The only exclusions are you have to be older than 18 years old. You are not you can't have an infectious disease like HIV, CJD, or anything like that, and you can't have anything that can compromise the brain pathology like a stroke. The tissue undergoes detailed characterization so that it can be used for research study, and it allows for collaboration with other brain and spinal cord programs overseas. The tissue is actually stored, so patients who are part of this program, when they pass away, they receive the death certificate. If they're at home or in the hospital, they contact the brain and spinal cord donor, who then organises through the normal funeral company for the body to go to Westmead Hospital to undergo the harvesting of the organs. And then the brain and the spinal cord are then stored at Neuron, which is based there on the Prince of Wales campus. So the only things that are needed is patient consent while they're alive. We have to have consent while they're alive, as well as next of kin consent or witnessing, and has to be a blood relative. We do prefer that patients attend either the clinic with us at the Forefront Clinic or with Dominic Rowe Macquarie Neurology, but patients who live, let's say, rural areas, they're still able to participate, and what we try and organise is for the patient to just come down for a day for us to do all the baseline assessments and to do the consent forms. So far we have 27 enrolled in the Brain and Donor Spinal Cord program, and 13 have donated their brain and spinal cords. An interesting project that we're currently in the middle of is the Lighthouse project. It's an antiretroviral therapy in MND. Is there a viral trigger or cause to MND? That's the question. So this dude down here, he's an infectious disease guy, Dr. Julian Gold. He's the person who came up with this project. And what his explanation is that 8% of our DNA is actually comprised of viruses. And one of those viruses is the human endogenous retrovirus, HERV. HERV is found in all 22 chromosomes. What can happen if that HERV is stimulated, or it comes out from the background? Can this HERV contribute to MND or cause MND? So one of the common drugs that's used in a HERV, which is the HIV, is this drug called Triumec, which is a combination of 3 antiviral drugs here. So patients, we recruited 10 patients at our site, and there were 3 other sites, 2 others in Sydney, 1 in Melbourne, so a total of 40 patients. They underwent a 2-month period of observation, and then 6 months of receiving the drug itself. Everybody received the drug. There was no placebo, and it's a safety and tolerability study. Most patients so far have tolerated it, except probably one where his liver function went a little bit out of whack. So it's a little bit early to see what the results are, but hopefully by early next year, Julian might come about with some results. So that's quite interesting. Does the virus play a role in MND? One other drug you might hear of in the news is Devarone or Radicart. It's developed by Mitsubishi Tanabe Pharma. It's been developed in Japan and Korea, and recently been approved in America. It's used in acute stroke originally, and now in MND. What it is a free radical scavenger used to treat, try to mop up all the oxidative stress that happens within the cell, which seems to play a part in ALS progression. Patients need to be, eligibility criteria is 20 to 75 years old, definite or probable MND, forced vital capacity of at least 80%, a score of at least 2 on all the items of the ALS-FRS, and they can't have the disease for more than 24 months. It's very strict. This group, this criteria, it doesn't capture many people. They based it on 2 registries in Ireland and in Netherlands, and if you plug all these into the system, only 7% of patients will actually be eligible to participate in this trial, which is equivalent, using our registry data, to 140 patients in the whole of Australia. So not many people. This trial is limited. It only looked at patients receiving the drugs for 24 weeks. So we only know that patients did better in those 24 weeks. We have no longitudinal studies. And another limitation is it's intravenous. Patients have the drug every day for 14 days, then they have 14 days off. They then have the drug for 10 days out of 14 days, and then 14 days off. So there's a lot of going, toing and froing, and then there's a lot of problems with venous access as well. So we're going to have to look into central lines when it does come. There's an oral version that is currently being looked at in the Netherlands. And lastly, masitinib, which is another drug that was developed by the French, recently presented in a conference in 2017 in May. And what it is, it's like an anti-inflammatory medication. They looked at patients, they had a group of 394 patients, divide them into 3 groups. One group received 3 milligrams per kilo per day of masitinib, combined with a normal dose of riluzole. Another group received 4.5 milligrams per kilo per day of masitinib and riluzole, and the last group received the placebo, 6 milligrams for another group and then a placebo for the other. And so what they found is the patients whose ALS-FRS was better was actually in the group that received 4.5 milligrams per kilo per day. So that is a drug that's hopefully coming around to Australia. We actually are currently doing a one-man trial. We use a special access scheme, and so I've got 1 patient on it at the moment and have no troubles at all with side effects or tolerability. In conclusion, MND is clinically heterogeneous. The heterogeneity of motor phenotypes, such as your PMAs, your ALSs, your PLSs, and your progressive bulbar palsy, is determined by your primary attributes, presence of upper motor neuron and lower motor neuron. Where does the disease begin? Bulbar, upper limbs, lower limbs, respiratory muscles, and also the rate of progression. Every patient is unique in its presentation. You can't compare one to another. We've got a number of trials in ALS. In the world, it's increased. Even in the 15 years that I've worked, it's just skyrocketed. So there's more therapies that are being trialled to date, and hopefully the outcomes of these trials will be positive.
Right.